Well, hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. So today's episode is going to be a follow-up to a recent episode that I did on over-the-counter painkillers. So in that episode, I talked about what to know about popular over-the-counter analgesics, such as acetaminophen and ibuprofen, brand names Tylenol and Advil, respectively. And it's been quite popular. Many thanks to those of you who have watched it or shared it. But I noticed in the comments that many of you had questions about what to do if those medications weren't enough to manage your pain. And there were also a lot of questions about prescription pain medications. So in this episode, I'm going to talk more broadly about managing pain in aging, especially chronic pain. I'll cover common types of pain and how we treat it, including medications. And specifically, what I want to cover in this episode is, first of all, what are some of the most common types of chronic pain in older adults. So in this episode, I'm going to focus on pain that is chronic and ongoing, and that is not cancer, because cancer pain is its own thing to manage. I'm going to talk about how this type of pain should be evaluated by health providers. I'm going to talk about how we think about it in geriatrics and the sort of principles that we use to manage pain in older adults. And then I'm going to talk about different ways to manage pain. I'm going to start with non-drug approaches to managing ongoing pain. And then I'm going to talk about medications and also other medical options for treating pain as well. So we're going to get started with that. But before I get into that, I have a very quick request, which is if you're here and you find this topic interesting, or you've been finding my video podcast interesting, if you haven't yet subscribed, could you please go ahead and subscribe? It would mean a lot to me. It really does help more people find the channel when you subscribe, and it helps support the work that I'm doing. So moving on, let's talk about chronic pain in older adults. So first of all, what exactly are we talking about? So a common definition for chronic pain or ongoing pain is pain that has been there for at least 3 to 6 months, or sometimes people say if it lasts beyond the expected time of healing. So I'm not going to talk a lot in this episode about acute pain, but a brand new pain or suddenly much worse than usual pain, you probably want to go see your health provider, get checked out. But here we're talking about how do we manage a pain that has been ongoing, maybe sometimes better, maybe sometimes worse, for at least 3 months or for longer than we would expect once some kind of injury was expected to heal. And this is an important issue when it comes to older adults, because chronic pain is fairly common in general, and it becomes even more common as we get older. The population that has the highest levels of chronic pain are people who are in their 80s and older. So studies have found that up to 50% of older adults report pain that interferes with normal function, that is interfering with them doing the things they want to do every day. And then we know that there are also a lot of other older adults who manage to function well despite having chronic pain. So it's still an issue for them. It's a quality of life issue, but they are still often fairly functional. We also know that it's fairly common for older adults to underreport pain. They may not report it to their health providers. This is sometimes because people have gotten the idea that it's normal aging, it's normal to be in pain when you're older, or they may believe that it's not treatable, that there is nothing to do. But this is not true. So let me share with you some truths about chronic pain in older adults. So first of all, it is common, but it should not be considered normal. It can and should be brought to the attention of health providers, and it should be medically evaluated and managed. And along with that medical management, I want to say that there are usually many things that can be done for chronic pain that don't fall within, medical care, meaning care that is covered by insurance, to be honest. But that additional non-medical management is usually very, very helpful. And I'm going to talk about some of those approaches in this episode. Because it usually is possible to treat pain, meaning to help an older person feel better and function better. And part of how we do this is we recognize that pain is often exacerbated by other factors other than the actual injury or damage to the part of the body that is generating the pain. So pain can be worsened by factors such as having depression, being lonely, having a high level of stress, having sleep problems, or having anxiety. And there are some other things that can contribute as well. So, treating chronic pain usually works best when we use a multidimensional strategy. So, we don't just want to rely on medications. That tends to not be very effective for people of all ages, but it's especially important when it comes to older adults who tend to be quite sensitive to medications for pain, especially the stronger ones. Last but not least, although it usually is possible to treat pain and make it better, it's often not possible to completely eliminate the chronic pain. So, usually, if you go into it with the goal of, and I'm going to be totally pain free, you're likely to be disappointed. However, especially with a good comprehensive approach, and I'm going to talk about what that looks like in this episode, it should be possible to significantly improve pain so that an older person can feel better, function better, and participate more actively in their life. Let's now talk about a few common types of pain in aging, because part of being successful in treating pain is to correctly identify what are the underlying causes, what's causing the pain, or often in older adults, it might be a combination. So here are some of the more common problems, medical problems that can cause pain in aging. So, probably most common is arthritis in one or more joints. Another one is chronic low back pain. Another one is lumbar spinal stenosis. Another one is something called myofascial pain syndrome. Another one that came up when I did my literature review for this is fibromyalgia, actually. And then another type of pain is neuropathic pain. So I'm not going to go through each of these in a little bit more depth and explain what they're like. Now, there are many, many other causes of pain in aging that exist. I mean, wide variety of health conditions can cause pain. But here I'm talking about some of the most common causes in older adults and some really broad categories that we want to be thinking about when it comes to chronic pain in older adults. So, arthritis, first of all. So, probably the most common type is what we call in medicine osteoarthritis. This is the kind of arthritis that is caused by what we call degeneration, so wear and tear, plus additional factors. It's really common for it to affect the large joints of the body, such as the hip, the knee, maybe the shoulder. But some people will also get it in small joints, like their fingers, or the base of the thumb, pretty common. It's also really common for people to get osteoarthritis in their spine. It can be in their cervical spine, the neck part. It can be in their lower lumbar spine or elsewhere. So that's a really common form of arthritis. And then there are other forms of arthritis that also affect older adults. So for instance, there are things like rheumatoid arthritis and other types of arthritis that we call inflammatory arthritis. There's actually, when I was in medical school, they would say that osteoarthritis is just degeneration with no inflammation. Now they've found that there are actually subtle signs of inflammation. But in rheumatoid arthritis, it's usually a whole other level of inflammation. And it's important to diagnose that and identify that, because that we often take a different treatment approach that really works on that inflammation when it comes to rheumatoid arthritis and some related conditions. And then another form of arthritis that affects a fair number of older adults are things like gout, and there's another related condition, pseudogout. This tends to affect one particular joint in the body. It might be, the knee is pretty common, the big toe is pretty common. Sometimes it can be in other places as well. Okay. Next, lumbar spinal stenosis. So what is this? So this is a condition where as people get older, age-related changes result in a narrowing of the lumbar spinal canal. So your spine kind of emerges from the bottom of the brain and, goes down in your back and is inside your spinal column, which are the bones, your vertebrae that are around it. That space where the spine is can get narrowed by age-related changes to the spine and to the bones, and that can put pressure on the end of the spinal cord and put pressure on the nerves for the lower part of the body. So that narrowing, again, can be caused by arthritis, also by disc degeneration, bulging of the discs in the spine. And so this ends up giving people symptoms such as pain, numbness, tingling, or even weakness. The symptoms are generally going to occur in the low back and lower down for lumbar spinal stenosis. So people tend to have symptoms, especially in their back, in their buttocks, into their legs and their lower legs. And the symptoms are usually worse when people stand or walk because that's a position that tends to generate the compression on the spine. But people often feel better when they sit or lie down. And actually, a really sort of classic symptom is that people will feel better if they lean over. So if they feel better when they're leaning over a shopping cart or if they're leaning over a walker, that can be a sign of spinal stenosis because that leaning forward tends to open up space a little bit and result in less compression of the nerves. So to diagnose this, it can be seen on lumbar spine MRI. But what you want to know when it comes to any kind of back imaging, when it comes to older adults, is that it's very common if you do a scan for there to be all kinds of changes on the scan and people aren't actually having symptoms. So we know that a certain number of older adults have spinal stenosis on MRI, but are not experiencing symptoms. And if that's you, I wouldn't panic right now. We know that in general, people can have lots of signs of changes on their scans and not necessarily have symptoms. And it's most important really to go with symptoms for this kind of thing. Next common type of cause of chronic pain in older adults is something called myofascial pain syndrome. So this is something that I think is not necessarily super high on the list of primary care providers. It's not something that I thought about all that much, to be honest, until I did this review. But what it is, it was listed in the UpToDate.com article on chronic pain in older adults. It was listed as a commonly overlooked cause of pain in older adults, so I think it's worth mentioning. And UpToDate defined it as a regional pain disorder caused by the presence of trigger points within muscles or their fascia. So, muscles in the body are the muscles. Fascia is kind of the layer of connective tissue between muscles and between parts of the body. And basically what this is that people will get like a knot, a kind of tight spot often in a muscle, and that creates pain. So the trigger points are these sensitive spots, and they do usually feel firm and like a knot in the muscle or fascia, and then they cause pain or other symptoms. And often that pain is a little bit further away than where the knot is. The pain is often deep and aching, and sometimes with burning or stinging. So it's important to identify this when somebody is having it, because as you'll see when I talk a little bit later about treatments, this particular syndrome does respond to manipulating those trigger spots. So if you find the trigger spot that is generating the pain a little bit further away and you apply a lot of pressure or sometimes put a needle in it, that can help it relax, and that ends up resolving some of the pain. So this is a good condition to get spotted if it's contributing to your pain. And it has some overlap with something that is called fibromyalgia. So fibromyalgia is a condition that I think was not taken very seriously for a long time in medicine. It still can be kind of frustrating for health providers because it tends to be ongoing, something people have for a long time and can be quite hard to treat. But basically, when people have fibromyalgia, they have widespread pain all over their body and also usually fatigue and sleep disturbances. But they have little objective evidence of inflammation in their tissues. And so that's why for a long time, this was thought of as something that was entirely in people's head. It's now believed that's not the case, although addressing the mind component is important in fibromyalgia treatment. One leading hypothesis is that this is a disorder actually of pain regulation, that people are sort of like inappropriately getting signals of pain from their body or perhaps created at some level in the brain. And people with fibromyalgia can have other symptoms such as cognitive symptoms, headaches, or bowel issues. And then they usually are tender in multiple spots on physical exam. It just doesn't feel quite like the same kind of knot or trigger point that we see in the myofascial pain syndrome. Next, neuropathic pain. So this is not a syndrome. This is basically a classification of pain, and it means pain related to injury or disease of the nerves. So most pain that people experience is actually in another category, which is called nociceptive pain, and it's pain caused by damage to the tissues, to the muscles, to the bones, to the connective tissue, to the viscera. But in neuropathic pain, the injury or disease is in the nerves themselves. So this usually gives pain a particular kind of quality that might be more like burning, shooting, stabbing, or electric. Can also involve numbness, tingling, or even weakness if it's one of the motor nerves that is affected. Some common causes in older adults include diabetic neuropathy, or if you've had shingles, that can leave you with neuropathic pain where you have the shingles. or if a nerve got damaged, that can also cause neuropathic pain. And there can be a few other causes as well, such as stroke or spinal cord injury. So let me now speak to chronic low back pain. So this is very, very common, but I put it last because what's important to know about chronic low back pain, especially in older adults, is that it often involves components of those other types of pain that affect older adults. So it's often created by a combination of arthritis of the spine. There could be a component of hip arthritis as well. There might be some myofascial pain. There might even be, some neuropathy happening if one of your spinal nerves is getting, kind of pinched after it comes out of your spine and could be giving you symptoms. And here also, the severity of symptoms when it comes to low back pain often doesn't correlate with the imaging. What we know is if you do X-rays or MRIs on older adults, 95% of them have degenerative changes, but less than half of them are reporting pain during the prior year. So when I talk about how pain should be evaluated, I'm going to talk a little bit more about imaging. But for now, I'll just say that when it comes to low back pain, it's good to think of it as like probably a multifocal problem. And so the most effective approach is to try to identify different components that might be contributing and see what can be done about each component and kind of take a sort of holistic view on the low back pain. So let me now talk about how pain should be evaluated when it comes to older adults. So for evaluating pain in general, often in medical school, we're taught this acronym that is called OLD CARTS. And it stands for asking about, when it comes to the pain, the onsets, how did it start? What brought it on? The location, where is it? The duration, how long have you had it? The character, does it feel deep, pressure, burny, stingy? Alleviating and aggravating factors, what makes it worse? What makes it better? Radiation, meaning does the pain seem to spread or go anywhere? Or is it really kind of like in a single spot? Temporal pattern, does it wax and wane? What's its kind of pattern? And then associated symptoms that you've noticed with the pain. So that's the kind of like fundamental stuff that we want to know about pain. So if you've been having pain, be ready to come in and describe all of those to your health provider. But it can also be really good for the health provider to ask additional questions and kind of identify what's sometimes called the pain signature. The goal here is to ask additional questions that can help the health provider identify the likely underlying causes of the pain, but also understand how the pain is affecting the person's life. How is it affecting their function, their ability to do things, their mood, their emotional state? What other impacts is the pain having on them? How are they experiencing the pain? Also, when the pain is being evaluated, it's important to review prior treatments, especially if people have had pain for quite a while. What have they already tried? How did it work? What was the effect? What are things that maybe worked a little bit? How did they take it? Often a treatment maybe hasn't worked because the person may not have given it enough time or may not have been able to follow through on it. What was the effect? And then, of course, there'll be a physical examination also. So this generally is going to review, especially the musculoskeletal system, since that's such a common cause of pain, and nerve function with special attention to painful areas. And then it's fairly common for some imaging to be done. What kind of imaging? So by imaging, I mean X-ray or MRI or sometimes CAT scan is what's most common. Occasionally, ultrasound could be done. In some musculoskeletal clinics, they actually do bedside ultrasound, like in sports medicine. So the imaging is going to depend on the symptoms. So especially when it comes to the back, imaging is useful, but it's usually most useful to rule out certain causes, certain less common things, than it is to tell you exactly what is causing the pain. So with imaging, we can see, well, is there, a vertebral fracture in there that is contributing to an older person's low back pain? Or, is there something growing in there that we didn't realize was there? So I think imaging is useful. It's just important to note that it's not going to completely explain the pain, and that it's super, super common to see abnormal, degenerative, so that means wear and tear, arthritis-y kind of stuff, findings in the joint and spine, and that those findings often don't align with the symptoms. And then your health provider might also order some blood work. It can help check for common medical conditions that might be related to the pain, depending on your health history and, the story of how your pain came on, your other chronic conditions. Or sometimes blood work is used to check for signs of systemic inflammation and make sure we're not dealing with something that might be rheumatoid arthritis or, some of these other inflammatory conditions that can give older adults a lot of pain. So let me now speak about how geriatricians think about treating chronic pain. So for us, we're often extremely focused on increasing or maintaining function, on helping an older adult be able to do more things, or at least still be able to do the things that they are doing. And we're also usually pretty diligent about assessing the older person's mobility and their cognition. And why do we do this? Well, first of all, mobility and cognition are really important for independence and quality of life, and they are often affected by pain. Furthermore, many oral pain medications make mobility and cognition worse. So we always want to kind of check and see how people are doing on that front before we start adding medications so that we can tell if the medications are having too much effect on that or not. We are also generally alert to the likely side effect of drugs and the risks of procedures. So our medical system in the United States tends to be very heavily tilted towards using prescription medication and procedures. There is definitely a role for those in treating pain and in healthcare in general. There's just also often other options that can be safer and more effective. That's especially true for older adults. And so we're generally thinking about the side effects of those drugs. And if we're going to use medications, we want to use them judiciously. And then in geriatrics, we really focus on, a comprehensive multifocal approach. We understand that tends to be more effective. So non-drug approaches are important to bring in and encourage. We use the medications judiciously, start low, go slow, use the minimum amount necessary. And we also try to involve an older person's care circle whenever possible, whether that's a spouse, adult children, friends, who else is there to support this older person and provide, encouragement and assistance as needed. So let me now talk about options for treating chronic pain. So in general, as you can see, there can be lots of different causes for chronic pain. So a one-size-fits-all solution is not realistic. A good treatment starts with that good evaluation, which identifies the underlying cause, or quite commonly causes, plus those exacerbating factors such as, is there any depression, loneliness, stress, sleep problems, anxiety? Because addressing those is going to make the treatment of pain much more effective. Another thing that's really important when it comes to treating chronic pain is to address the psychological aspect. Pain is an experience. So yes, your body may, be injured or have damage and be sending the pain signals. And we know that there's a very powerful way in which the brain's response can amplify or diminish that pain response. So there's lots of evidence that psychological treatments can help people learn to cope more effectively with pain, which means that their experience of pain improves. They might either experience less pain or be less distressed by it. And that can result in, being more functional, able to do more, and in better quality of life. And I'm going to talk about medical treatments. And again, they are valuable, things like prescription medications and procedures, but they are generally going to work best when they're combined with the many other ways to basically, activate the body's healing response and or change how the body and brain signal pain and process pain. So let me now talk about some of those non-drug responses that have been studied and found to be effective or important or useful when it comes to treating chronic pain. So in no particular order, physical therapy. Again, depends on what's the cause of the pain, where the pain is, but often there is a role with physical therapy in helping people with their pain. Definitely been shown for arthritis and for other forms of pain as well. Exercise. Exercise has been shown to reduce pain in many circumstances. Now, you want to be sure to have an exercise that is suitable, that fits with the kind of pain you have, other, issues you might have with mobility or vulnerabilities. But in general, things that are going to be helpful are going to be things like gentle yoga. You want to be careful with yoga. Don't do the yoga for 20-year-olds. Gentle yoga and Tai Chi tend to involve movements that are fairly gentle and also have stretching and flexibility. Aqua therapy can be really great. Exercise that takes place in the water that can be good for sore joints, especially, or arthritis. Another non-drug approach that has been studied and often is effective for reducing pain is acupuncture, actually. Also to be considered would be massage and or relaxation therapies, heat or ice. You might have to experiment a little bit and talk to your provider to figure out which works better for your type of pain. If it seems like you might have those trigger points, those knots, those myofascial pains that are kind of generating more pain at a small distance away or right around that trigger spot, it is possible to get trigger point therapy. It can be manual, meaning, rubbing with the finger to release that spot. There's something called dry needling where they just put needles in it, or they sometimes inject with saline. And this has been studied and found to be effective. Another thing I want to mention is dietary changes. I know a number of older adults who find that they are sensitive to certain things in their diet. For some people, it's dairy. For some people, it's sugar. For some people, it's gluten. And that when they cut back on those, for some people, it seems to be alcohol too. When they cut back on those, they find that their arthritis and general aches and pains gets significantly better. So I think some people are sensitive to certain foodstuffs, and that those foodstuffs increase, levels of inflammation in their body. So I think it can be worth experimenting with that and trying it out and seeing if you yourself experience decreased pain when you change certain dietary factors. And then there is also Reiki and other forms of energy healing. Now, you may think this sounds like very woo, but some people feel noticeably better when they get it. And there is, we do have biochemical, energy in our cells and in our bodies. Chinese medicine actually works a lot on, focusing on those energies and affecting them through acupuncture in parts. And so maybe this really works. Maybe this is activating your placebo response. But what I would say is that anything that safely activates the placebo response is actually worth trying because it is relatively safe. And if it helps you feel better, that is important. So to a certain extent, we experience less pain when either our body learns to restore itself better or when it signals pain less to us. And so anything that activates that is something worth considering and potentially pursuing. And then there are the non-drug approaches that specifically address the mind. So psychotherapy often has a really important role to play in treating ongoing pain. So first of all, it can be used to treat coexisting conditions such as depression, anxiety, or sleep issues, and also to help people learn to cope with pain. There are cognitive behavioral therapy programs specifically for pain. And cognitive behavioral therapy also exists and has been studied and found to be effective for insomnia as well. And then there are other forms of therapy as well. There's also cognitive behavioral therapy for anxiety, for depression. I mention it because right now it's a form of therapy that is really often covered by insurance. It's not necessarily going to be most effective for you or the best thing. I would say work with, whatever seems to work for you and is also financially accessible to you. But we certainly have seen good results with cognitive behavioral therapy for pain and for insomnia. Then there are things like mindfulness practices and stress reduction. It can be various forms of meditation that can help with this, and that can also help reduce the experience of pain. And then there's pursuing activities and social connections that reduce stress and increase emotional well-being. So for a lot of people, nourishing social connections help quite a lot, and their pain might be worse when they're not getting as much of that. It might be better when they do get more of that. Or there can be, different activities that increase people's emotional well-being. For some people, for most people, actually getting out into nature helps. For some people, it's things like gardening, playing music. There's, a wide variety of things that can help increase people's emotional well-being. And now let me speak to a few other non-drug approaches for pain. Some of these fall more within like medicine. One thing that people have occasionally asked me about is transcutaneous electrical nerve stimulation, TENS. So this basically involves a device that has, patches or pads, and it delivers electrical energy to the tissues and the nerves. It used to be available only by prescription and only with health providers. Now I think there are devices that you can get over the counter. It's had mixed results in studies. It might depend a little bit on the underlying cause of pain, but it does seem to help some people. It does seem to be safe. So I think it's not unreasonable to give that a try and see if it works for you. Another approach that has historically been used, especially for arthritis, are joint injections. So it's true that you can get an injection of an anti-inflammatory steroid, something like prednisone, into your knee, especially is fairly common to be done in clinic because it's not very hard to put a needle into the knee. Occasionally, it can be put elsewhere. So this does provide short-term pain relief. Generally, especially the first few weeks, can last up to 2 months. But studies have found that the pain relief isn't there after 4 to 6 months. And studies found that there was potentially a risk of the arthritis accelerating because steroids can interfere with healing. So as of right now, the expert guidelines generally do not recommend that people use a lot of joint injections for arthritis. They should be used kind of judiciously if it's really important, short-term to, reduce pain, but it's not a long-term strategy. Another type of injection that was studied a lot for arthritis were injections of something called hyaluronic acid, but that was found to be no better than placebo in studies, so no longer recommended. And then occasionally, there's also been some experimenting with something called platelet-rich plasma, but that too right now has not really panned out in research studies. Then, depending on the type of pain you have, there are pain specialists. They often have trained in anesthesia who do various kinds of procedures, injections and other things. Depending on the kind of pain you have, they might be worth looking into. There may or may not be a good evidence base. So I recommend just once you find out what's recommended for you, seeing if you can do a little research online. You can go to scholar.google.com or PubMed and search actually the AI overviews right now, are often not bad, and just try to find out what the evidence is for it. And also find out what would be the risks, what are the likely risks, or what are the known risks, and what would be the likely benefits. And then for certain types of pain, sometimes surgery is an option. So surgery comes up especially when it comes to joint replacements, right? Knee replacements, hip replacements, sometimes shoulder, and then also spine surgeries. And what you should know is that joint replacements actually have a pretty good record of improving pain and function. That's provided that you're not too high risk for the surgery and that you're able to tolerate and participate in the rehab. On the other hand, spine surgeries have a much less good track record. A lot of people still have pain afterwards. So if you're thinking surgery, you should know that overall, the joint ones tend to be effective for reducing pain. The spine ones, I would be a little bit more careful before proceeding along that route. But of course, talk to your health providers because you may have a particular case where you're extremely likely to experience significant resolution of your pain from spine surgery. And then there can be some other sort of procedures as well. Depending on the type of pain, they try all kinds of things, implantable devices and all that. I'm not going to get into those, but here are some of the ones that I get asked about the most often. Let's now talk about medications. So what's most likely if you go to the health provider and say you have chronic pain, what's most likely is that something will be prescribed. So what is often prescribed for pain and what do you need to know about it? So the choice of drug for health providers generally depends on whether the health provider thinks what type of pain the health provider thinks the patient is dealing with. Are we talking about nociceptive or neuropathic? So again, neuropathic pain is related to damage or disease of the actual nerves, and nociceptive is kind of like damage or disease of all the other tissues of the body. And what you need to keep in mind is almost all oral medications are considered risky in older adults. But what do we tend to use? So for nociceptive pain in body tissues other than nerves, often the first choice, and it is often effective for improving pain, is a nonsteroidal anti-inflammatory drug, also known as an NSAID, such as ibuprofen and naproxen, which are available over the counter, or a prescription strength one such as meloxicam and diclofenac. These do relieve pain, but they also come with significant risks, especially for older adults. And in my previous related video on over-the-counter painkillers, I went into the risks of NSAIDs in depth. So if you haven't seen that, I recommend you see that. But really briefly, one of the risks is bleeding in your stomach or in your bowel. Among older adults, 1% of them will bleed within 6 months, 2 to 4% within a year. And other side effects are also possible. NSAIDs affect kidney function and they affect cardiovascular risk. So they're very useful for a short-term pain, but if you have ongoing pain and need to be taking something every day for weeks or months on end, you want to be careful about NSAIDs, especially when it comes to older adults. Now, they do exist in topical forms at times, and those are much, much safer. They don't get systemically absorbed. They get a little bit systemically absorbed, but you're absorbing into the body much less than when you take it orally, and so the risks are much lower. And after that, there's really opioids. Nowadays, they are supposed to be used as a last resort after trying lots of the non-drug therapies and, potentially the NSAIDs or other approaches as well. Because, as you probably know, opioids come with a risk of sedation, which can be life-threatening, right? Fatal overdoses are not uncommon. They come with a risk of dependence and addiction, and they have other risks. That said, sometimes there is a role for them. So in my own geriatrics practice, at times I have used low-dose Vicodin. That's a combination of hydrocodone and acetaminophen. Now, another type of some other opioids that historically have been often prescribed are codeine and tramadol. But these are actually not recommended by expert guidelines or in the guidelines for geriatricians. And it's for a couple of reasons. One is that they're much more variable in effect. And then tramadol in particular is more likely to have cognitive side effects and interactions with other medications. So the recommendation right now is to actually avoid using those too. And if you're going to use an opioid, go to the stronger ones that are considered cleaner. I would say this is after you've tried a little low-dose Vicodin. But the trouble with Vicodin is since it has acetaminophen, Tylenol in it, you can't keep increasing the dose. So if you need more than that, what's recommended is to go to a, quote, cleaner opioid, such as morphine or oxycodone. There are a few others that are also considered cleaner. I didn't list them all over here. But you have to be careful with these. And among other things, I think nowadays you have to be careful that these drugs don't get diverted by somebody else in the house and misused. And then let me talk briefly about prescription medications for neuropathic pain. So for neuropathic pain, we tend to use different types of medications. So one class is what's called SNRI, antidepressants. That stands for, hold on, it's a mouthful, serotonin norepinephrine reuptake inhibitors. There we go. Not to be confused with SSRI, antidepressants, which are selective serotonin reuptake inhibitors. But the SNRI ones are specifically medications such as duloxetine and venlafaxine, brand names Cymbalta and Effexor. So these have been studied and often are actually effective in treating the pain of nerves and reducing them. However, they do have some side effects. They do increase fall risk a bit. And then venlafaxine in particular can affect blood pressure and the heart. And also, if people abruptly stop it, can cause all kinds of sort of discontinuation symptoms. So I would probably lean more towards duloxetine for an older person. Another type of medication that has a long history, a long track record for neuropathic pain and is definitely effective would be medications that fall in the class of tricyclic antidepressants, such as amitriptyline and nortriptyline. These aren't used for depression anymore. They're used mostly for nerve pain, including for pain after an episode of shingles. The problem is that they're quite anticholinergic, especially amitriptyline, and so they can affect cognition and balance. And anticholinergic drugs also give people pesky side effects, such as dry mouth, dry eye, and constipation. So that's another type of medication that we want to use very cautiously in older adults. And then also for neuropathic pain, anti-seizure medications work. This makes sense because seizures come from nerve cells in your brain neurons kind of getting a little hyperactive. And so seizure medications calm them down. And so likewise, if a nerve is hyperactive and sending pain signals, seizure medications should calm that down. So some of the anti-seizure medications today that are used quite often for pain are gabapentin and pregabalin. What you need to be careful about when it comes to older adults with these is that they can cause sedation or dizziness. Now, we see fewer side effects with something topical such as lidocaine patches. These can also be used for neuropathic pain. And then let me speak to a few types of medication that are sometimes used but are not generally recommended anymore. First of all, muscle relaxants, medications such as cyclobenzaprine, the brand name for that is Flexeril, or baclofen. Not recommended anymore, not found to be effective when it comes to chronic ongoing pain, but can cause problematic side effects. And then also sedative tranquilizers such as lorazepam and other benzodiazepines are not recommended anymore for neuropathic pain or for other types of pain. And so that is what I had to share today about pain and aging. So let me recap now the key points and takeaways that I hope you will retain from this episode. So chronic pain is common but should not be considered normal. You want a comprehensive evaluation to help identify the cause or causes. Often there are going to be multiple causes. And again, what's common in aging is arthritis in one or more joints, often throughout the body once people get into their 80s or 90s. Also common is lumbar spinal stenosis, myofascial pain syndrome, fibromyalgia, neuropathic pain, and chronic low back pain. When you're thinking about treating chronic pain in older adults or really in anybody, you want to also check for any exacerbating factors because it's very common that people's pain is being made worse by problems such as depression, loneliness, stress, sleep, or anxiety. And then the goal in treating chronic pain is to improve the person's daily life function and quality of life, to reduce the pain and make it more manageable. Total elimination of chronic pain is often not possible, but usually it is possible to make it better. The geriatric principles for treating chronic pain in older adults are to use that customized multimodal approach, customized to what seems to be going on with the person. Multimodal because you want more than medications. You want as many sort of like of those non-drug approaches as you can to make the pain treatment successful. And you want to address those exacerbating factors whenever possible. Non-drug approaches are invariably going to be safer for older adults and often come with other health benefits as well. We focus on improving mobility, function, quality of life, and then we use oral medications judiciously, carefully, as almost all of them are risky in older adults because the non-steroidal anti-inflammatory drugs, the NSAIDs, affect bleeding risk, kidney function, and cardiovascular risk, and most other pain medications affect cognition and balance, and some are potentially dangerous and habit-forming, such as opioids. So because I think it's so important to consider, implement, try non-drug approaches for pain, I'm going to recap again what those are. Physical therapy, exercise, especially gentle yoga, tai chi, stretching, aqua therapy, acupuncture, massage and relaxation therapies, heat or ice, trigger point therapy if you are experiencing myofascial pain, dietary changes can reduce inflammation and symptoms in some people. I know many people with whom it reduces their arthritis symptoms. Can consider Reiki and other forms of energy healing. It might work for you. And then again, anything that safely activates your placebo response and helps your body either restore itself or changes the way your body and brain interpret pain signals, any of that can be good. And then we also want to incorporate the non-drug approaches that address the mind aspect of the pain experience. So psychotherapies to treat coexisting conditions such as depression, anxiety, sleep issues, and to help with pain coping. So cognitive behavioral therapies for pain, for insomnia, or other forms of psychotherapy for depression and anxiety are also good. And then you want to think about mindfulness practices and stress reduction. And last but definitely not least, extremely, extremely important, is activities and social connections that reduce stress and increase emotional well-being. And so if you combine all of that with sensible use of pain medications and medical procedures, you should be able to experience a reduction in chronic pain or get it to a point where it's manageable and you can still enjoy your life the way that you would like to. So with that, thank you for watching. And if you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe. It does help more people find the channel. If you've been listening to the audio version on the podcast feed, come and take a look at the video if you get a chance. You'll be able to see my key points being displayed on the screen. So thank you once again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.